One of the problems that people encounter in an area like this is that they're highly dependent on the literature to guide them. I'm not saying that that is wrong, but I can tell you from my many years of experience of writing scientific papers that scientific papers are very stilted. In a scientific paper, you must create a dichotomy. Uh, I did this test, and either this result or that result was the outcome. And when we're talking about ovarian masses, the typical dichotomy is, does this finding predict benignancy or malignancy? But I want to tell you that that should be one of the farthest thoughts from your mind. When I find an ovarian mass, my first thought is, if I'm just smart enough to realize it, isn't this a lesion that will simply go away by itself? And that is because in females of every age, and I mean females from fetal life through death, the most common lesion that you will find in the ovary is not a neoplasm of any kind. It is a non-neoplastic cyst. This is far and away the most common ovarian mass. If we confine our thinking furthermore to those lesions in the size range between 2.5 and 6 centimeters, so our upper and lower limits, then overwhelmingly these lesions will be non-neoplastic. Non-neoplastic cysts are seen in both pre- and postmenopausal women. If 25 years of endovaginal sonography has taught us anything, it is that the postmenopausal ovary is not this dead lump of tissue that we used to think that it was when I was in medical school. It is, in fact, quite dynamic, so I'm sure you're already familiar with the fact that you may see a cyst. In a postmenopausal woman, she returns and it has completely disappeared. A typical course for a non-neoplastic cyst. This has been well researched in the literature. Depending on what one is willing to call a cyst, the range of incidence is between 4 and 17%. I would say Bailey is about right. It's somewhere around 5%. The resolution is going to be about half. So about half of the cysts of less than 5 centimeters seen in the ovary of a postmenopausal woman will disappear. But here is the most important piece of information. These don't have anything to do with cancer. Now, the important factor is that non-neoplastic cysts will almost always spontaneously regress, and I give you my personal guarantee that if you practice gynecologic sonography for 30 years, you will be able to count on one hand the number of non-neoplastic cysts that continue to grow under your observation and ultimately went to the operating room for surgical removal. There are a large number of non-neoplastic cysts, but we're only interested in the big three. We're interested in the serous inclusion cyst, not because it's large, not because it's symptomatic, but because this is a cyst that is seen in postmenopausal women. That is a non-neoplastic cyst. And we're interested in the follicular cyst and the corpus luteum cyst because these are accidents in ovulation. And thus, with millions of American women ovulating every month, we don't have to have a very high percentage of accidents for us to see a lot of these follicular and corpus luteum cysts. Now, I want to caution you that a Graafian follicle is a normal structure. A follicular cyst is an abnormal structure. A corpus luteum is a normal structure, but a corpus luteum cyst is an abnormal structure. So when you're constructing your reports, you should discriminate between those terms. Now, it behooves us to go back to an era when imaging did not influence whether a gynecologic surgeon removed a mass that they palpated in the patient's adnexa. And Carpenter's data serves us well in that regard. What you can appreciate is that in Carpenter's era, 80% of the time, surgeons took out a lesion which, had they left it alone, would simply have disappeared. And what was the advantage of all that needless surgery? Well, approximately 5% of the lesions they removed were neoplasms. Of those, 77% were benign and 23% were malignant. And had they known that these were metastatic deposits in the ovary, they wouldn't have removed those either. Well, that study teaches me something very important, and that is I am going to approach every ovarian mass in a premenopausal woman knowing the chance is strongly against it being a neoplasm of any kind, not a malignant neoplasm. It is very unlikely that it's going to be a neoplasm of any kind. So, if I'm looking at the sonogram and the thought flies through my brain in a nanosecond that this lesion could probably or even possibly be non-neoplastic, then by all means I want a follow-up sonogram. Because if the lesion disappears, I can send the patient back to the gynecologist with a report that says normal ovary. The next important question to ask after how big is the lesion I'm looking at is the lesion a unilocular cyst or not? Now, most radiologists and sonographers and obstetricians think that they know why that's such an important question, but usually they do not. The reason it's a very important question is because all non-neoplastic cysts are unilocular, which means I have the mindset that I find a mass and I immediately think I'm looking at a non-neoplastic cyst. If that cyst isn't unilocular, then I'm wrong. Now, these tiny follicles that we were pointing out are important for two reasons. First, these are not septations. It's very important that you understand that septations are one of the hallmarks of ovarian neoplasia. Therefore, if you put the word septation in your report, any reasonable gynecologist is going to think you're talking about an ovarian neoplasm. Now, obviously, we will use the word septation in our reports at times, but when I use that word, I want to be absolutely certain that another word that's going to come out of my mouth is that I think this is a neoplasm. The other important aspect is that these follicles confirm that this mass is indeed in the patient's ovary. The reason most sonographers and sonologists think unilocularity is important is because they realize that ovarian neoplasms that are unilocular cysts are almost invariably benign. And that is true as well and very important. Now, here we have a lesion that is a unilocular cyst and anechoic. And this is the way they are frequently described in the literature and in advisory papers. I do not use anechogenicity when I am thinking about unilocularity. Here is a unilocular cyst. It has some echoes within it. That doesn't stop me from thinking of this as a unilocular cyst. As well, and equally importantly, tiny mural excrescences do not make me think of this as anything other than a unilocular cystic ovarian neoplasm. Now, with those excrescences, I can be more confident that this unilocular cyst is an ovarian neoplasm than I can that this unilocular cyst is an ovarian neoplasm. But I look at these two lesions and think benign ovarian neoplasm. So again, here we have a unilocular anechoic cystic mass in the ovary that's larger than 6 centimeters in diameter. I'm thinking neoplasm. I am thinking benign neoplasm. Now, here are 6 studies from the literature looking at unilocular cystic neoplasms of the ovary. 212 of them, so a significant sample size. And you can see that only 3 of them were malignant. That means that if we see a unilocular cystic neoplasm of the ovary and call it benign, we have a positive predictive value of 98.5%, and that is awesome. Importantly, 2 of the 3 lesions were larger than 10 centimeters in size, so it was never a question of whether the lesion was going to be surgically excised. The error was that we would consider it to be benign, but the pathologist would sign it out as malignant. Now, I usually don't quote literature like this in my lectures, but this paper by Motasit from 2003 had one of the most remarkable statements I've ever seen written in the medical literature. Now, the group was following 15,000 women over the age of 50 in a cancer screening program. And they were talking about lesions that were 10 centimeters or less in diameter. As you know, I use 6 centimeters or less. They detected 3,200 unilocular cystic ovarian neoplasms, so a remarkably large, those were not neoplasms, 3,200 unilocular ovarian cysts in the population under 10 centimeters in size. 70% spontaneously resolved. Now that's higher than we noted in those studies that I showed you on postmenopausal women, but these were women over the age of 50, a significant proportion of whom will not be postmenopausal, so they will have a higher spontaneous resolution rate of cysts found in their ovaries. Now for the statement that literally blew my mind when I read it. No woman with an isolated unilocular cystic ovarian tumor has developed ovarian cancer in this population. So again, I cannot overstress this. We worry about ovarian cancer. We'll talk more about ovarian cancer. But when you find a mass in the ovary, there should be 3 other thoughts in your mind besides ovarian cancer that you're considering, because ovarian cancer is not likely to hide from you. On the other side of the coin of unilocular cysts, there are a whole bunch of them. And if it's your plan to say exactly which unilocular cyst you're looking at, then you're going to experience a lot of disappointment in your life. The very common ones are the follicular cyst, the corpus luteum cyst, and the endometrioma. Less common, para-ovarian cyst, serous inclusion cyst, and serous cystadenoma. Our first ovarian neoplasm, and a benign one. Uncommonly, cystic teratoma, mucinous cystadenoma, and cystadenofibroma. These are not uncommon ovarian neoplasms, but they are uncommonly seen as unilocular cysts. And let me further caution you that in the cases that I have seen billed as unilocular cysts, the mass was almost always incompletely evaluated, and there were other components of it that made it not a unilocular cystic mass. Rarely we will see a cystadenoma of low malignant potential, the so-called borderline cancer, or a frank serous cystadenocarcinoma. Now, these are certainly in the literature, and I don't deny those reports. But what I can tell you is that in 35 years of gynecologic sonography, I have never seen one. I have seen several examples of this. I'll share some of them with you. Here's the first one. This was a 57-year-old woman who had this rather large mass in her ovary. You can see that it had echoes within it. You can see that it had tiny papillary excrescences from the wall. So I was convinced that this was a neoplasm. I was convinced it was unilocular, and I thought it was benign. The patient, because of her age, did go on to have a CT scan, which again showed some thickening of the wall at various locations, but also a unilocular cyst. And the diagnosis on CT was benign ovarian neoplasm as well. So the surprise was that the pathologist signed this out as a borderline cancer. Here are two other patients who had large unilocular cystic masses of the ovary, and in both instances, the pathologist signed these out as borderline cancers. So, one of my personal rules is that if I encounter a unilocular cyst of the ovary that is larger than 10 centimeters, then I add the provision to my report that occasionally the pathologist will sign out lesions in this size range as borderline cancers. Now, it's interesting what pathologists call borderline cancers compared to gross pathology. After all, you and I are gross pathologists. We get to look at that. We're not handed a microscope to examine our sonogram. Now, I've just shown you 3 unilocular cystic ovarian neoplasms that were signed out by the pathologist as borderline cancers. This lesion was also signed out by the pathologist as a borderline cancer, and as a gross pathologist seeing this wall irregularity, I can kind of get behind that. Yeah, I would have thought it might be benign, but I wouldn't be terribly surprised that the pathologist called this a borderline cancer. On the other hand, here is a lesion that I thought was malignant, and again, the pathologist signed that out as a borderline cancer. So this lesion, and those unilocular cysts were all signed out as borderline cancers. Now, because of that, I never make an effort to decide what is a borderline cancer. I know that I am almost certainly going to fail, and every time I start bringing that subject up, I will only confuse the issue diagnostically more than clarify it. Now, I want to point out to you that we all know that pathology is the gold standard, and I am not here to tell you anything different than that. But I'm here to tell you that pathologists are as human as radiologists, obstetricians, and sonographers, and they make mistakes as well. And I can tell you that I have made this statement many times. Had I relied on pathology reports as I tried to advance the field of prenatal diagnosis, I would have set my progress back a full decade. Because pathologists knew less about congenital abnormalities of the fetus than I did. If you want to read a paper that will help you to understand that pathologists aren't always going to get it right when they look at a pathologic specimen of an ovarian lesion, read this paper by Dr. Levine and her associate, a truly excellent paper, Histologic, Surgical, and Imaging Correlation